want to start with the view from Capitol Hill. How are things looking from your view?
They're looking quite interesting, I would say. I did want to start with a short disclaimer that this is for educational purposes. We really look forward to be able to talk with you again. Please keep it in that mindset. All views expressed today are my own, and cannot be construed as the senator's. But for Capitol Hill, it's ongoing pandemic. We have a new administration, new congressional makeup. Priorities include ongoing vaccine distribution to help get us out of this ongoing pandemic, and dealing with what we're going to look like post public health emergency, the after effects of the pandemic. So what is our healthcare industry going to look like? What is our health insurance going to look like? What are some of the new health policy waivers that we've passed under CARES and through our various COVID relief packages that we've had during that pandemic that we might want to have post-pandemic? We also have a record drug epidemic on our hands. We experienced over 90,000 overdose deaths in 2020 as an estimate. Those numbers are likely to go up. West Virginia, as you may know, leads the country in drug overdose deaths. So negotiating that, and Congress passed the American Rescue Plan in March. So we're still going through implementation of provisions from that, especially in the healthcare space. We have enhanced Medicaid funding for our home and community-based services, and we have funding for our hospitals and health centers and various health providers that still needs to go out the door. Various grant programs for rural health providers, for folks suffering and treating those with behavioral health and substance use disorder, addressing related comorbidities associated with that. So increases in new HIV cases, hepatitis infections, suicide rates. And the president's budget was just released last Friday. So we're going to have to be diving here into healthcare appropriations. We've seen the president's budget calls for about a 23.4% increase in HHS funding alone. So we're going to have to dive into that. And prescription drug pricing is still a big issue on the horizon. So there is a lot coming up. There's already been a lot in healthcare. We've passed several COVID bills, of course, and there's still a lot more to do. And the House has passed several pieces of legislation dealing with these issues on drug pricing. And the Senate will have to review some of these proposals coming down the pipeline. And what exactly that looks like is going to be a question. Obviously, we have a 50-50 Senate, and the Senate is a great deliberative body. And so we will need to deliberate on these issues. And infrastructure is coming down the pipeline. Healthcare is included in the proposals, specifically those home and community-based services that I mentioned. So it will be interesting to see how that progresses. And there's a lot of work to do, and we're just getting started. And looking forward to answering any questions to continue this conversation. Also happy to continue working on these issues.
I will second all of Audrey's disclaimers that the comments are my own and represent Stuart Portman's thoughts on Capitol Hill and not Senator Crapo's. Audrey did a very good job of making those nice formal disclaimers, and so I will second them fully. But I will say that things are looking very busy, although in a very different kind of way. So I've been on the Hill now for a little over 7 years. So I've been both in the majority and now in the minority. Lots of people like to tell you the minority can be more fun. And I think that the world of health policy is so serious that people have to remind me to have more fun and stop thinking, the world of Medicaid is inherently one that, despite what you may think, because of what you may read, there's a lot of bipartisanship that happens behind the scenes and frequently in front of the scenes as well, more on stage, because Medicaid is so complex. And my role is primarily to be the senior advisor on all issues related to Medicaid and the Children's Health Insurance Program for the Senate, specifically on the Senate Finance Committee. But if it touches Medicaid, I get to view it for the GOP in the Senate. It's a very cool role, given that, if you are, the longer you're involved in health policy, the more times you will hear that if you've seen one Medicaid program, you've seen one Medicaid program, a delightful little mantra, given that there are 56 different Medicaid programs. But my job is to actually know all 56 of them, which is the 50 states, DC, and the 5 territories, which will be relevant, and I'll explain why in just a moment. But I, got my start from completing my Master's of Public Health across the river from George Mason. So went to George Washington University for my MPH, and was able to really dive in, learn a lot about Medicaid, learn a lot about health IT. Did a lot of health IT specific research as a research assistant while doing my MPH. And prior to that, came to this from being one of those pesky pre-med majors, someone who went and studied biology, and I, still have my chemistry minor, which randomly becomes useful when studying drug pricing and having to talk about new therapies, as well as lab bench research, doing forensic genetics, and actually working on a couple of gene therapies from the lab bench side. So exciting times, a different sort of background to coming to Capitol Hill, but love the world of health policy. And I would say day to day, a lot of what we're working on is similar to what Audrey mentioned. I would say that the Senate is a deliberative body, and depending on the day, it can be a deliberative body because of Audrey's boss, or it can be a deliberative body because of my boss. And that's what makes it so great, is because there are personal relationships that, to the public might seem like you're causing something that could be seamless to take an extra 8-9 hours, but it happens, and then everyone comes together in the end and they're able to pass it. So it's quite an interesting experience, but I would say that I would agree on a number of the issues. It goes without saying that the priorities that we have are going to exist regardless of what happens in the forefront, which is this budget reconciliation. Is there going to be an infrastructure bill? Is there going to be a care economy bill? Are they actually going to be one bill? Is it going to be bipartisan? Is it not going to be bipartisan? Is one of them going to be bipartisan? The other one won't be. Those sorts of questions dictate how the year goes. So we work a lot to get the policies that have to pass done behind the scenes, so that we know how to fit them in based on the type of vehicle, which frequently means, an easy example here is drug pricing. There is a lot in drug pricing that is bipartisan. There's also pieces of the drug pricing proposal that the Democrats have championed that the Republicans do not like. And so the question is everyone going to come together, or is everyone going to go into their own lanes? No one really knows the answer. So we have to prepare for both options. And within those, there can be sub options. And so we do a lot of the groundwork, which means we prepare the text. We work on making sure that the language itself is viable and can be implemented. We get technical assistance from the Centers for Medicare and Medicaid Services. We get estimates of how much it will cost or save from the Congressional Budget Office. We talk to stakeholders that are going to be affected across the board. Those are things that have to happen in any scenario. And so you just talk about multiple scenarios at the same time and figure out how to plug in what's actually happening as more is decided at the member level. Part of the role of the staff is to be prepared for any contingency, and that means being prepared in advance of learning what the plan is. So that means we are doing a lot of that type of work. I agree, there's going to be a lot of conversation on how flexibilities that have come about during COVID can be continued. The most glaring example is the use of telehealth, and whether or not there's going to be more telehealth, where you saw telehealth rising up, how, if you're talking about audio and visual only, if you're allowing audio only, if you're talking about e-consults or remote patient monitoring. Telehealth is a big, broad moniker that means a lot of different things. And in the Medicare program, there likely needs to be some changes to the statute to allow for more telehealth, whereas, as frequently not understood, in the Medicaid side, states can already do a lot in the telehealth space. Texas last week approved the use of telehealth. They passed a bill taking the pandemic flexibilities and making them permanent in their Medicaid program, including audio only, which was a surprise to many because some people love it, truly love it, especially where there's concerns about broadband, and others are worried about the potential for gaming of the system if you have audio only. Or can audio only work in some circumstances better than others? Is it good in a use case related to behavioral health? Because that situation may call for it more than the use of telehealth in other scenarios? Where have we seen, what does the data say we've seen an increase in use, and what are the surprises? Not as many people expected to see children's hospitals embrace telehealth as much as they have. What can we learn from that? Those are the sorts of questions that we're going to dive into across the board when we talk about pandemic flexibilities and what can be continued, what requires Congress and what doesn't require Congress. Can the administration waive certain authorities more broadly? Can states waive certain authorities? That sort of question has to be asked, but we need data to back up all of our claims. And thankfully, there's a lot of data coming in from the last 15 months. A very sad half glass full kind of spin to the difficulties that have arisen during COVID. And so you'll see more of that kind of a conversation occurring. But as I mentioned, there are must-pass vehicles. Lesser known to many is that Medicaid in the US territories is an authorization that gets a finite amount of time. It is not an open-ended funding stream like it is for the states. And that open-ended funding stream comes to an end September 30th of this year. There is a little bit of base funding that can continue beyond that, but the majority of how they operate and the enhanced FMAP that they use has been increased over the last several years and is now at the delightful level of 83%, the top end of Medicaid funding, because it's between 50% and 83% for your federal matching rate. And the 4 small territories are at 83%, and Puerto Rico is at 76%. So all higher than most, or if not all states. Puerto Rico and Mississippi might fight it out, depending on the day of the week, what their FMAP may be. But otherwise, you're talking about territories being at the higher end of an FMAP and how much money they can receive. But that is a must-pass vehicle. Whether or not you are fascinated by the nature of Medicaid in American Samoa or not, that is a must-pass vehicle, which means that everyone else will try to attach their ideas to this must-pass vehicle. And how successful they are is a question of what does leadership allow, what does leadership push back on, how wide of a package do they want, how small a package do they want. In December, we passed a very broad package of healthcare priorities that slipped in along with a lot of COVID policies, but things that you may have heard of, like surprise billing reform, might be a little more in the spotlight. But there were also components like making sure that all Medicaid enrollees have the ability to have their routine care covered in a clinical trial, which was a state option up until this point, and it caused a lot of health disparity related issues to occur in the Medicaid program because you were excluding large segments of the population from participation in clinical trials, which has a lot of ramifications on the equity and the representation of the trial itself. So that sort of thing is now law. That's exciting. We're going to follow up on implementation of that. But again, that made it because it was a must-pass vehicle and member priorities were included. So that will be a huge component of the rest of this year. And the final thing I'll say is that there will be a lot of oversight. One of the sadder side effects of COVID is because of all the changes that took place. For those of us policy nerds that love the world of health data, the data that you're getting in some areas like telehealth is great. The data you're getting on broader use of services, whether it's claims related or audits or anything that you may need to actually evaluate the effectiveness of a program and make sure that the dollars are going where they need to go, that data, not so great right now. Very difficult to evaluate. Similarly, when you look at duals data, duals reform is something that's gained bipartisan support over the last few years. And I think that there actually is a desire to act probably next year on really reforming how we take care of the duals. But we can't rely on any recent data because as one of the components of giving enhanced federal matching funds, increasing the FMAP for states, any state that accepted those dollars, which was every state that took that additional 6.2%, which translated to many billions, they were not able and are still not able to disenroll anybody from the Medicaid program until the end of the month in which the public health emergency ends, and the declared public health emergency is still ongoing, which means that if you aged onto Medicare, and this was changed by guidance at the end of last year, if you aged onto Medicare during the pandemic, you have about a 10-month window in which everyone was 65 and suddenly they were a dual because it couldn't be disenrolled from Medicaid. And so looking at how that tracks with the data, how can that be changed in the back end? Those are like little nuancy things that actually play a large role in how we think about the real world impacts of the policy changes that are written into statute. So I know I just threw a lot at you. but I wanted to make sure that I could cover all of our bases and can go into more detail when we get to the questions, of course, and happy to look forward to all the questions that may come.
Excellent.